Vamos a dar inicio a la jornada de la tarde. La primera conferencia está a cargo del doctor Bob Boyle. El doctor es pediatra, alergólogo e inmunólogo pediatra del Royal Children's Hospital y la Universidad de Melbourne, Australia. Es doctor en medicina de la misma universidad y se desempeña ahora como consultor y reader en alergia pediátrica del Imperial College de Londres. El doctor nos hablará acerca de prevención de alergia alimentaria.
Hola, buenos días. I want to say thank you to the organisers for asking me to talk about the prevention of food allergy. I'm Robert Boyle, based in London with Marta at Imperial College. First, my conflict of interest. I do editorial work, expert witness work. I don't have any direct conflicts with companies profiting out of the topics here, but Nestle have a partnership with our university which doesn't involve me. Today I'm going to talk about how to prevent food allergy. I'm going to talk about three main areas. Milk feeding, especially the role of hydrolyzed formula, the timing of introduction of allergenic foods like egg and peanut in a baby's diet, and then how best to look after baby's skin and whether that makes a difference to the development of food allergy. The reason I'm going to talk about those topics particularly is because when we did a very comprehensive synthesis of all the literature around allergy prevention and diet for the UK Food Standards Agency a few years ago, we found that most of the work has been focused around timing of allergenic food introduction and use of hydrolyzed formula. And the main non-dietary intervention of interest at the moment is infant skin care. So that's why we're focusing on those three topics. First of all, milk feeding. Obviously, for most babies around the world and through history, they're breastfed. And there have been questions raised around, does the duration of breastfeeding influence risk of food allergy? The short answer is we don't know, but there's not a lot of evidence to suggest that breastfeeding directly influences risk of developing food allergies. The only real clinical trial evidence we have in this area is from the PROBIT trial, where they tried to implement World Health Organization guidance in an area where breastfeeding rates were quite low. So World Health Organization guidance, you probably know already, is to exclusively breastfeed babies for around 6 months before introducing complementary food, and then to continue breastfeeding for 2 years or beyond. And that the 2 years sort of fits with a lot of cultures and human history. The 6 months is more directly out of direct evidence around gastrointestinal health and the protective effects of exclusive breastfeeding in those first months of life. And I should say that, coming from Europe and speaking at a Latin American conference, there's not much that we can say about breastfeeding. Breastfeeding rates are very low in Europe, particularly in the UK where I'm from, and obviously much closer to the physiological norm in much of Latin America, although this picture is changing quite rapidly around the world. So back to that trial, the only trial of where we can get sort of randomized evidence around breastfeeding and an allergy is the PROBIT trial. This is a large randomized controlled trial in Belarus in Eastern Europe. And breastfeeding rates were very low at that time, and they randomized clinics to have an educational intervention along the lines of the WHO recommendations or not. And in the clinics where breastfeeding was supported better, there was less eczema at follow-up. No change in asthma, no change in skin prick tests, although these were for inhalants, and really no information about food allergies. So other than a signal around eczema there, we don't really know whether encouraging prolonged breastfeeding prevents food allergy from developing. There's no real direct evidence around that. But this eczema signal comes out in other data sets as well, that early introduction of formula feeding may cause skin rashes and eczema. And that's what led the formula industry to focus on this idea of chopping up proteins in infant formula to see if alternative types of formula, hydrolyzed formula, might reduce risk of eczema or food allergies compared to standard cow's milk formula. I'm going to focus a little bit on this now because there have been a lot of clinical trials in this, and for most of the past 30, 40 years, if you look at recommendations for preventing allergies, you'll find that whether it's American, European, Latin American, Asian societies have been recommending the use of hydrolyzed formula for infants to prevent the development of allergies. And you can see that on these labels here. They're called hypoallergenic, and they're saying it's to reduce the risk of developing allergy to cow's milk proteins. So that claim has been there for many decades. And what I just want to do in this piece of the talk is interrogate to that, show you that the claim is not true, or not supported by good scientific evidence, and ask a little bit about, how did we get to the situation when recommendations were made to use this formula for decades without very good evidence. The sorts of places that have made these recommendations, I've just given you some examples there, but many societies around the world have sort of given strong approval for these sorts of claims. And some of that was based on small early trials, and then a Cochrane review in 2003, which suggested quite a strong effect of reducing eczema when you use one of these low allergy formula milks instead of a standard formula milk. No one's ever claimed that they're better than breastfeeding, but people have claimed that this type of formula perhaps has special allergy prevention properties compared to a standard formula. And this positive meta-analysis was largely driven by these two positive trials from the group of Ranjit Chandra in Canada in the late 1980s. And really it wasn't until some years later that a news documentary questioned whether Chandra's trials had actually happened at all. And it turned out that the Chandra trials were almost certainly fraudulent, and they've been, at least some of them have been retracted from the journals, and most people have assumed that those trials probably didn't happen, or the results are not reliable when they've looked at this since then. So the first issue with this field is the issue of scientific fraud or alleged scientific fraud. When you take the Chandra trials out of the meta-analysis, it looks much less convincing. But positive claims continue to be made for hydrolyzed formula even after the Chandra trials had been retracted and withdrawn from analyses. And there are two reasons for that. One of them is that a trial that really didn't show any positive effect, in fact possibly a harmful effect in regard to eczema, was buried for many years. So it wasn't published for 11 years after it's finished. So that wasn't in meta-analyses done between 2000 and 2011. And then the second issue is that this other trial, which again didn't show any clear evidence that hydrolyzed formula prevents eczema, was selectively reported. So the initial publications did not show the full data set, and they showed per protocol data sets, or data sets that made the effect look more exciting than it really was. So that combination of a delay in publication of the null trial and then selective reporting of this other trial gave the impression to people that there was a helpful effect there, and that supported all these recommendations and guidelines that hydrolyzed formula was useful. You'll see when we looked at this in 2016 for the UK government, we saw nothing there really. This is a very null forest plot, no suggestion of a benefit for hydrolyzed formula in preventing eczema. When you look at milk allergy, which is the other claim, there's really even less evidence there. So these sorts of claims have been made and they've been supported by guidelines until recent years. And that, for milk allergy, really there's almost no information. There are 3 trials, but tiny numbers of people with milk allergy in each trial, and again no suggestion of a decreased risk at all. That's for partially hydrolyzed formula. This is for any type of hydrolyzed formula, similar picture. This is for when you're looking at skin prick tests or specific IgE to milk. Again, no sign of a benefit there. So I really don't think there's much evidence that hydrolyzed formula is preventing eczema or food allergies there. And when you step back and think, well, how on earth did the whole allergy community for 30, 40 years, get so misled that we're all recommending to our patients and then guidelines that this formula has special properties. It's partly due to conflicts of interest. And what you see if you go to allergy conferences and meetings is the formula companies, paying people to give talks, supporting conferences, giving educational symposia, etc. And it was quite disappointing for me to see that the formula industry have been supporting this meeting, as they do many allergy meetings. And there's been quite a move against that, starting with the World Health Organization, through the World Health Assembly, the United Nations health body, who recommended that the formula industry should not be sponsoring conferences, healthcare professional, educational meetings, etc. That that's not appropriate, and it leads to these sorts of situations where science gets misunderstood, and people end up recommending things to their patients which subtly undermine breastfeeding and promote certain formula products. I'll give you an example of another example of how this can go wrong. We did a trial of partially hydrolyzed formula some years ago for a formula company, and found that this partially hydrolyzed formula was associated with a rate of eczema which was 28.7%, and that was exactly the same as the rate in the control group. So this was a null trial, multi-center, a randomized control trial. A survival analysis looked like this. Really no meaningful difference between the partially hydrolyzed formula and the standard formula. But the company, the formula company, when they present the results, or when they presented the results on their website, they said this, that the partially hydrolyzed formula, it can be an effective strategy with a double impact to reduce the risk of developing allergy in high-risk infants. That's completely different to the understanding of the people who did the trial and their interpretation of the findings. This was a null trial, but being presented by the company as positive findings. And that's just an example, really, of how the commercial pressures lead the companies to present science in a slightly different way to an objective, independent scientist. It's a long story, the hydrolyzed formula story, and as I've alluded to, you've got scientific fraud, you've got data which are not presented properly, and they're retracted abstracts, etc. A lot of conflict there, but essentially 30-40 years of the waters being muddied by formula industry involvement in too close involvement in scientific processes and assessments, etc. This is not unusual. The formula science sponsored by formula companies, clinical trials particularly, are really unreliable. There's very little reliable information being put out there. They're not very transparent. There's selective reporting going on. So this is just an example, I think, of the types of things that happen with the infant formula industry. These sorts of realizations have led journals to boycott formula company advertising, and they've led health professional organisations, at least in the UK or Northern Europe, to boycott financial relationships with formula companies. So the Royal College of Paediatrics doesn't take any funding from formula milk companies, and nor do all these allergy and paediatric organisations in the UK and Ireland. And that's in keeping with what WHO and World Health Assembly recommend, that we should not be having these commercial relationships with the formula industry. So I would call on the organisers of this conference to just reconsider whether it's appropriate to have formula industry funding at future events like this. The thing that triggered a lot of that activity was the realization that milk allergy guidelines, again often developed in close collaboration with formula companies or disseminated by formula companies, are really pushing over-diagnosis of milk allergy, at least in some countries. So this particular guideline is quite widely used in some countries. When it's applied to the EAT data set, it suggested that 3/4 of babies might have milk allergy, which is preposterous. No epidemiology suggests that more than 1 or 2% of babies have milk allergy, but this guideline, widely disseminated by the formula industry, is promoting overdiagnosis, and you see that, low allergy formula milks in England being used at perhaps 10 times the expected rate. So about 90% of low allergy formula prescription in England is probably unnecessary. So that's enough about milk. The second thing I wanted to touch on for this presentation is introduction of allergenic foods to the infant diet. Now, about 110 years ago, someone called H.G. Wells, Gideon Wells, discovered the phenomenon of oral tolerance. It wasn't H.G. Wells who was a famous British author. It was H. Gideon Wells practicing in Chicago at exactly the same time. And what Gideon Wells discovered was that he was studying this newly recognized phenomenon of anaphylaxis. And he identified that you could make guinea pigs allergic to egg by injecting egg under their skin, hen's egg, chicken egg. But if you put egg in the guinea pig's food from soon after birth, it was almost impossible to make them allergic. So feeding an antigen early on in life can prevent the development of allergy. So that was subsequently shown in many different animal models, a very well established phenomenon in animal immunology. However, it took 100 years before we proved that that also works in humans. And this was another Gideon Lack in London, who led the LEAP study together with George Dutoit, and supported by the Immune Tolerance Network. And as you probably know already, that feeding peanut to young babies early on prevented the development of peanut allergy very, very effectively. There have been a number of other trials now, and it's fairly clear that both for egg and for peanut allergy, oral tolerance works. So if you feed babies egg or peanut early on, before they've developed allergy to these foods, then you can significantly reduce the risk of them developing egg allergy by about a third, and peanut allergy by more than that. It seems to work slightly better for peanut than for egg for unknown reasons. It hasn't really been proven to work for milk yet. Quite mixed studies. The latest study, which it was the Prevent et al. Study published in the Lancet a few months ago. They used peanut, milk, egg, and wheat, and they fed them to young babies in the first months of life, and they're quite flexible in their regime. There was quite a pragmatic trial. They allowed the parents some flexibility in how much they gave, and this seemed to prevent food allergy. Again, it seemed to work best for peanut rather than anything else. So the peanut, rather than having 2% peanut allergy, this was reduced to just under 1% peanut allergy, even lower in those who actually took peanut. Less conclusive outcomes for milk and egg, and wheat allergy was so rare that they couldn't show anything there. So essentially we have moderate strength evidence that early egg introduction from around the time of complementary food introduction reduces risk of egg allergy, and early peanut introduction reduces risk of peanut allergy. We don't really have much evidence for other allergenic foods at the moment. And that's led, of course, to many governments in countries where food allergy is a common problem to recommend that babies are exposed to egg and peanut. Obviously not whole peanuts, that would be dangerous for babies, but peanut butter or other forms of peanut flour in foods as normal weaning foods to get babies used to these things. To put this in perspective, if you're a baby, at least a UK or European baby, you've got about 5% chance of having an egg allergy. If you're given egg early on in your life, then that will reduce to about 3% chance. So what that means is you need to give egg early to about 40 babies to prevent one case of egg allergy. So that's a sort of not a very exciting number needed to treat. However, if you take young babies with bad eczema, so early onset severe eczema, where the risk of developing an egg allergy is really very high, perhaps as high as 50%, then the number needed to treat becomes much smaller. So for young babies who've got eczema, early onset eczema, they're at high risk of food allergies, then it becomes quite important to try and introduce allergenic foods early. Whereas for the average baby without a strong history of allergy, it's perhaps less critical. It's for families who are worried about allergy, it's worth considering. but it's not for every baby. Some parents are not going to be that interested in feeding their baby egg or peanut butter regularly to prevent allergies when their child is very unlikely to get allergies anyway. So similar picture with peanut. The number needed to treat is about 50 for an average UK child with about 2% chance of getting peanut allergy. And then for a high-risk child, where the risk might be of peanut allergy might be 10 or 20%, then the number needed to treat is lower. So in summary, for timing of allergenic food introduction, feeding infants egg and peanut from around 4 to 6 months of age, so whenever complementary foods are started, can reduce the risk of egg or peanut allergy developing. However, the complication with this story is that some children already have egg or peanut allergy by the time they're 4 or 6 months old. In some studies, they've shown up to a third of infants with eczema already have an egg allergy by the time they're 4 months old. So that makes it difficult. If you introduce egg or peanut to those babies, they'll have an allergic reaction. The families will not be very pleased with you. And that's where sometimes a more tailored approach is needed, where an allergy specialist might screen, look for evidence of food allergy, or maybe just introduce the parent might just want to introduce the egg or the peanut in the doctor's office rather than do it at home, and then carry on at home if there's no reaction. The last area I wanted to talk about is infant skincare. Now we know that most children who have food allergies, who develop food allergies, had eczema as young babies. And there's a very close relationship between eczema and food allergy. In fact, this is our sort of model for how eczema and food allergy develop at the moment. And there's been quite a lot of efforts to consider, well, if we try to prevent the skin from being damaged either through inherited genetic mutations or through environmental damage, then perhaps we could reduce skin inflammation, prevent eczema happening, and thereby prevent food allergy from happening. And you know, we've got this dose-response relationship between the severity of eczema and risk of food allergy developing, especially the early onset eczema tends to be associated with much stronger risk of food allergy, and that dose-response relationship suggests possible causality, that eczema may be a cause of food allergy. People have looked at moisturizers, and there was some early evidence about 10 years ago suggesting that applying a moisturizer to a baby's skin once a day may effectively prevent them from developing eczema. And that spurred 2 large randomized controlled trials, the BEEP trial and the Prevention trial, both published in the Lancet 2 years ago. And unfortunately, moisturizers do not seem to prevent eczema from developing, so this was a very null trial again. Rather surprisingly, applying moisturizers to the baby's skin from birth seemed to increase the risk of them developing food allergy. So this is suggesting a second thing we need to be careful with food allergy. Not only is it's good to encourage parents to include egg and peanut butter in the baby's diet, but it's also perhaps wise not to push moisturizers and other skincare products too much, because you may actually be increasing the risk of food allergy by handling the skin a lot and putting a lot of moisturizers on. We can talk perhaps in the Q&A about how that might be happening. But this was a surprise signal from the BEEP trial, and we've done an individual participant data meta-analysis from all the moisturizer trials, and again it shows a very similar picture to the BEEP study. So there's no real evidence that moisturizers are preventing eczema, but from both BEEP and the other large trial Prevention, there's some evidence that moisturizing baby's skin every day may be increasing risk of food allergy, perhaps by 1.5 times. So that's all I'm going to say in this initial presentation, and I look forward to more discussion at the Q&A later on Saturday. But my summary here is that hydrolyzed formula has no proven role in preventing allergy and shouldn't really be recommended in guidelines for this purpose. World Health Assembly Resolution 69.9 recommends no sponsorship of scientific meetings by formula companies. So again, I would call on the organisers to reconsider that relationship for future meetings of this society. Early egg and peanut introduction does appear to reduce risk of egg or peanut allergy from developing, but we talked about some safety issues when the children are very high risk there. And daily moisturizers don't seem to prevent eczema from developing. In fact, they may even increase the risk of food allergy developing through transcutaneous sensitization. Got quite a lot of people to thank who've contributed to the data here. Despo and Vanessa from Imperial who contributed to the systematic reviews work at the beginning, and then Daniel, Hilary, Michael, Shreya and Melanie who've contributed to more recent work around milk allergy overdiagnosis particularly. So thank you very much for your attention.
Muchísimas gracias, doctor Robert, por su excelente presentación y por el esfuerzo para conectarse. Sabemos qué hora es en este momento en Londres. Vamos a hacer un par de preguntas. ¿En el auditorio hay alguna pregunta?
Muchas gracias, doctor Boyle, por su excelente presentación. Me gustaría que conversara un poco sobre algo que no vi en su presentación, que es la diversidad, la introducción de los alimentos en forma diversa, no solamente la dieta, sino alimentos alergénicos. ¿Podría comentar al respecto sobre prevención en food allergy?
Thank you. Yeah, thank you for your question. So something that people talk about a lot is diet diversity, and sometimes people talk a lot about the influence of diversification of the diet on microbiome. But there's very little direct evidence around this. So certainly for the clinic, I don't think we need to be changing the diversity of people's diets to try and prevent food allergy or eczema. I don't think we have good enough evidence that that's a causal influence. So that's the short answer. It's an interesting research topic, diet diversity and how it changes across culture and through history, and the impact on the microbial composition of the human intestine and impact on health and disease. But it's not really something that's got a practical clinical application at the moment. So I don't think you need to worry mothers by trying to make them feel bad for not giving enough different foods to their child in terms of allergy. Obviously, there are other reasons to try and diversify a child's diet around, learning to different tastes and textures, etc. But not really for allergy.
Yo tengo una pregunta, doctor. A nuestro consultorio es usual que lleguen las mamás embarazadas que ya han tenido un niño con una alergia alimentaria o con una dermatitis atópica y nos llegan preguntándonos qué podemos hacer para que ese bebé que viene en camino se disminuya el riesgo de padecer alguna alergia. ¿Qué recomendaciones podríamos darle a esa mamá?
Thank you. Yes, I'm very familiar with that scenario. It's a difficult scenario. I think the first thing I would say is that over the last 40 years, allergists have been saying different things, and they change all the time. And I think the mistake that the allergists have made is to use very, very weak evidence and turn that into a recommendation. And sometimes that has caused more harm than good. So my first piece of advice is to not do too much, because I don't think we really know, for a pregnant woman how to prevent their child getting allergies. What I normally say is that the next child may get allergies, but they may not. Allergies are largely genetic, and so if the next child develops eczema early on in the first 2 or 3 months, then they're at risk of developing food allergies and persistent eczema, and they should come and see me again, and we can talk about early allergenic food introduction, because I think the only thing we know that works really is introducing allergenic foods earlier rather than later, and in a child who gets eczema in the first few weeks or months of life, then that's worthwhile doing. That'd be my main recommendation. I don't think we have any good evidence around mother's diet during pregnancy or breastfeeding. Yeah. And for skin care, I've shown you the 2 big trials. They show that moisturizers don't seem to be very helpful, but actually moisturizers may not be, they may actually be harmful. So I think if the mother really wants to know about skin care, then my advice would be to to try not to do too much to the baby's skin, so not to wash them too frequently, put too much moisturizer on, lots of soaps. All these things can be physiologically damaging to the skin barrier, and it's possible that they'll be promoting allergies. But we don't know that. I think the only thing you can say with confidence is that it's best to give allergenic foods earlier rather than later.
Doctor, y con respecto al uso de probióticos, prebióticos, simbióticos, suplementación con vitamina D o con PUFA, ¿hay alguna evidencia?
Yes, there's evidence. So for vitamin D, I don't think it does any harm, and most people around the world have low vitamin D levels these days because we live indoors. So most government recommendations would be for pregnant women to take vitamin D, to give vitamin D to their children. So there's no harm in that. I don't think it's going to prevent allergies. There've been a handful of trials. There's no real sign of preventing allergies from that. For PUFAs, polyunsaturated fatty acids, there's some weak evidence there but I think again it's too inconclusive. So again, you might take them for general health reasons, but I don't think they've got any specific benefit for preventing food allergies. And then you mentioned probiotics and prebiotics. I think with prebiotics, there have been more trials, and there's more trial evidence that they might prevent eczema. But I personally have become less convinced with that story over time. I don't recommend these for my patients, and they can cause harm. So the probiotics can occasionally cause an infection in someone, or they can cause stomach upset. And so particularly for the babies themselves, I really wouldn't advise parents to give these to the baby directly. Sometimes pregnant women take them, and I guess if it's not, if they tolerate them, then that's okay. But I don't think I don't think there's sufficient evidence for prebiotics to recommend them for preventing allergies. The formula companies will make claims around prebiotics because they put prebiotics in their products a lot. But as I've tried to show, the science behind that is very weak and often quite biased. So I don't think, again, there's a good rationale for a good allergy reason for using prebiotics early in life.
Muchísimas gracias, doctor Boyle.